Good morning. I'm Michelle Levander, Director of the Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Inside the Black Box of Healthcare Spending Data, offered thanks to the generous support of the National Institute for Healthcare Management Foundation. We'll take for our point of departure for this webinar fundamental questions raised by the research of Zach Cooper, Martin Gaynor, and their colleagues, who've analyzed the largest collection of private health insurance claims ever assembled. What they've learned is fascinating. Most savvy consumers already suspected that higher prices didn't necessarily translate into better healthcare quality. Now we're learning, based on their groundbreaking research, that hospital consolidation is proving to be the driving force for higher prices in markets across the country, and the market muscle of hospital chains is accelerating amid a wave of mergers. These economic forces are so powerful that communities once hailed for having the most reasonable healthcare costs in the country based on Medicare data turn out to be far more expensive when examining pricing in the private market. Here to explain all this and to offer their ideas for what comes next are Zach Cooper, an assistant professor of health policy and economics at Yale University, where he directs the Institution for Social and Policy Studies Health Center, and Martin S. Gaynor, who holds the E. J. Barron Professorship of Economics and Health Policy at Carnegie Mellon University. Martin is also the former director of the Bureau of Economics at the Federal Trade Commission. Zach and Martin are two of the co-authors of a National Bureau of Economic Research working paper we'll be focusing on today. We'll also hear from Dan Gorenstein, senior reporter for Marketplace's Health Desk and a former Center for Health Journalism National Fellow. He'll be providing some ideas on how journalists can explain and analyze these trends. Before we get started, I wanted to share a few operating procedures, and then we'll hear from our speakers. We're going to we have so many of you on our call that we're going to hear from our speakers first, and then we'll open it up to questions for the final 20 minutes. And what we'll ask you to do is to share your question in the question field in your control panel, and then we'll read them out. If you have technical challenges, please also text us through that question or comment field. You can tweet about this webinar at #HealthCosts. Thank you, and now we're going to turn to Zach.
All right. Well, hello, everybody, and thank you for joining. I'm sort of visualizing people out there who've got my slides on one half of the screen and an ESPN or their emails on another. So this is the first in the series of papers I'm working on with Marty Gaynor and John Van Reenen and Stuart Craig, where we're really drilling into healthcare spending for the privately insured. And we're thinking about what role providers' prices play in driving the variation in the growth in health spending for the privately insured. And what we're going to do in today's sort of segment is look at this first paper, which really looks at three things. We think about how healthcare spending for the privately insured varies across the U.S. That is, what areas spend more and how those patterns compare to Medicare. We're going to think about the role that providers' prices play in driving that spending variation. And then we're going to think about how and why hospital prices vary across the U.S. And I think the reason this is so important is one of the things that the Affordable Care Act does for very good reason is that it mandates every individual buys health insurance. And if we look last year at data from Kaiser, for the average family of four in the U.S., an employer-sponsored health insurance plan is going to cost about $17,545. And you can get a pretty good car for that price, right? You can get a Toyota Corolla, and I've been using this example a lot, so I actually went out and drove a Toyota Corolla, and it's actually a pretty decent car. And in addition to paying $17,545, we still see that about 1 in 5 people with employer-sponsored health insurance are going to have a lot of trouble paying their bills. They're going to take on credit card debt. They're going to postpone vacations. They may even take out payday loans or file for bankruptcy. And up until now, really most of what we know about healthcare spending, we know from the analysis of Medicare data. And there's been great work by Dartmouth, but the rub is that Medicare covers about 16% of the population. 60% get their healthcare coverage from private insurers. And there are reasons we could think that the patterns for Medicare and the patterns for the privately insured look very, very different. And a key driver of these differences is the way that we pay for healthcare. So Medicare is a price setter. They regulate prices, and they tell hospitals what they will receive. And a hospital in, say, New York is going to make more than a hospital in Montana because it's got a higher cost of operation. On the private side, prices are market determined. And so you have the thousands of hospitals coming together with the hundreds of insurers every year and negotiating over those prices, the prices that these insurers are going to pay for their policyholders. And in those sorts of negotiations, bargaining power matters. The bargaining power of hospitals and the bargaining power of insurers. But up until now, we really haven't been able to see prices. Hospital prices have been treated as commercially sensitive. And so we have this enormous black box with this absolutely massive sector of the economy. What we've tried to do in this paper is crack open that black box and look at health spending for the privately insured and then drill down on prices. I want to unpack that work and I want to talk about our data. So the data is really, key for this paper. So we're getting data from the Healthcare Cost Institute. And what we're going to do is we're going to analyze data from Aetna, United Health, and Humana. We're going to look at their employer-sponsored claims, and we are going to have a whole lot of people. We're going to have data on nearly 1 in 3 individuals in the U.S. with employer-sponsored coverage, 88.7 million people in our data. We're going to have data on 1% of GDP per year. And we're going to have it at an incredibly granular level. And critically, we're going to have prices. We're going to know what hospitals charged. We're going to know what insurers paid, and we're going to know what patients paid out of pocket. And so basically, for all care funded by these 3 payers from 2007 through 11, we're going to know what money went out the door and to whom. And this is really something fundamentally different than we've ever been able to do before. Right? You have a very, very hard time knowing the prices of different services. We're going to know them. Now, there are certain restrictions. We're not going to be able to name hospitals, for example, and there are some limits to what we can report. But we've tried to be incredibly transparent with our data, and on our website, healthcarepricingproject.org, we're going to have everything available to download so that folks can use them in any of their coverage, or people can use them, for example, when they teach their class. So the first thing I want to show you is the different prices that we see in healthcare. So if we look at this chart and we focus on hip replacement, the blue box, this is going to be what Medicare pays. So they're going to pay on average for a hip replacement about $13,195, which is 55% of what private payers are going to pay. They're going to pay $24,046, but the charges, a hospital is going to charge 185% of what they're actually getting paid. And up until now, we really have known mostly about charges. This, for example, has been what the Department of Health and Human Services has released. Charges were really the basis for a lot of Stephen Brill's work when he did some very nice reporting about different charges at different hospitals. And we see that basically the relationship between charges and what a hospital is actually paid is incredibly weak. Correlation is about 40%. So we've got the real data. We've got these real prices, and we're going to drill in and see what's happening. So let's take a look at spending. On the left, this is a map showing Medicare spending per beneficiary per HRR. That is how much Medicare spends per person. And this is data from the Dartmouth Atlas. It's risk adjusted for age and for sex and for race. And you get the sort of traditional understanding of healthcare, which is that health spending varies by a factor of 3. That is, McAllen, Texas, spends about 3 times as much on healthcare as what's across Wisconsin. And what Dartmouth has shown us is that the reason these expensive places spend more is because they do more. They have more MRIs, and they hospitalize you more frequently. They're more generally going to put you in an ICU. And that makes a lot of sense, right? So health spending, any spending, is a function of how much care is provided, the quantity, and the price of that care. And for the most part, prices for Medicare are fixed. So the only thing that makes a certain area expensive is that area does a lot of stuff. We're going to compare that pattern to what we see for the privately insured, and I've now put that map up on the right. That map looks very, very different. Right? Many of the areas that we see are low spending in Medicare are very, very high spending for the privately insured. In fact, we see a correlation of about 14%. Right? That is virtually no correlation. And one of the facts that really jumped out at us hugely as we got through this work is many of the places that have been used as examples for the nation for policy on the basis of the Medicare spending end up being tremendously expensive for the privately insured. So Grand Junction, Colorado, where the president traveled shortly before the Affordable Care Act got passed, it ranks as the third lowest spending area on Medicare. It ends up having the 9th highest prices in the country. It ends up being the 43rd most expensive place to get care in the U.S. of the 306 markets we examined. Rochester, Minnesota. It's the 14th lowest place for Medicare, the 11th highest area for the privately insured. Or La Crosse, Wisconsin, which actually ends up being the lowest, the cheapest area for Medicare. It ends up being the 22nd most expensive place to get private health insurance. And so what we do is we sort of drill into why we see these differences. Why does the world for the privately insured look so different? And we engage in a decomposition that we talk through in the paper, and the answer is prices. The answer is that in a place like Grand Junction, well, it doesn't provide that much care, while its quality is fairly low on both the public and the private side. It's very, very high price. That price is really a key arbiter of healthcare spending for the privately insured. And so what I want to do from here on out is I want to drill into price. And I want to see what we've learned using this unique data for the first time, which lets us take a snapshot at hospital prices across the U.S. So this is a map of regional level hospital prices from our data. And there are a couple of things that jump out. The first is really the extent of the variation. So the most expensive area in the U.S. on average is about 4 to 5 times more than the cheapest. Now we still see that places like San Francisco are expensive, right? They're expensive for, if they have high prices for other things, they tend to have high prices for healthcare. But a lot of the areas where we see high prices are areas that you just, wouldn't expect to see prices be that high, right? Like I just didn't expect the Dakotas or Wyoming to be an area of the country with some of the highest healthcare prices in the nation. And so when we jump ahead, what I've done in this graph and we've produced in our paper is we put up hospital prices, in this case for knee replacements, in 6 different areas in the U.S. And the blue is what Medicare pays, which really doesn't vary that much. The red is on average what the private payers pay for a knee replacement in these areas. And what you see is that the price of a knee replacement in Grand Junction, Colorado is more expensive than it is in Boston, in Philadelphia, or Chicago. And so what we're going to do is we're going to unpack why the prices in Grand Junction, why the prices, for example, in Rochester are just so high. But before we get there, I want to look at prices within geography. So not just across the nation, but within cities. And if you drill into that, you see some striking patterns. So we've put up 6 hospital referral regions. We got 118 online available for download. And each one of these columns, this is a hospital. And this is the price that hospital is going to charge for lower limb MRI. And these are basically services where quality doesn't vary. And if we look at the lower right in Houston, Texas, the most expensive hospital is about 5 times as expensive as the cheapest. Absolutely striking variation for a service which I think we can all agree doesn't really vary. So what we're going to do is we're going to think about, well, why could this be? Why could prices vary by a factor of 5 for an MRI in a single city? Why could in Miami the price of an MRI vary by a factor of 9? Why across the country could a knee replacement vary by a factor of 17? Right? What could cause this absolutely extraordinary variation? And we've tried to sort of categorize the explanations we see in the academic and policy literature. And one story that you often hear from hospitals is the reason they're so expensive is because they're just so good, right? Their quality is 5 times better than their competitors. So we bring in data on hospital quality. You maybe hear that the perception of their quality is high, so we bring in data from the U.S. News and World Report. One argument is that different hospitals have different pricing structures. Maybe teaching hospitals are more expensive, so we look at that. Maybe it's these private hospitals, these for-profits. Maybe they're more expensive, so we take a look at that. We look at their cost of operation, and we see how that affects pricing. We also look at this idea of cost shifting, right? Maybe the problem is that Medicare is underpaying, and that's leading them to raise their price. Or perhaps it's what economists suspect, which is that it's market power, that it's hospital and insurer market power that really influences price. And we're going to drill into each of these and try to unpack which seems to be most highly associated with price. That is, when we look at that graph of MRIs here, what's explaining why those hospitals on the right side of each of these graphs is so expensive? And what we end up finding is that the most substantial variation is explained by hospital market power. That if you're a monopoly hospital, you've got prices that are about 15% higher than if you're facing 3 or more competitors. Duopolies have higher prices, triopolies have higher prices. And we actually see the flip side on the insurer side. So as insurers are bigger and more powerful, they're actually able to negotiate lower prices. We see that high-tech hospitals, so there's a hospital in the top quartile of technology, they've got higher prices, but not that much higher. Bigger hospitals, they've got marginally higher prices. We see no difference for teaching hospitals. There's no significant difference between for-profits and not-for-profits. And in fact, if you're a hospital that sees more Medicare patients, you've actually got lower prices. We bring in data on quality, and we find no statistically significant relationship between hospitals' risk-adjusted death rates and their prices. Now, we do find that if hospitals are going to give you aspirin before you have a heart attack, and they're going to do that way better than their peers, that's going to get you about a 3% price premium. Being ranked by the U.S. News and World Report gets you about 13%. But the variable that seems to matter most is hospital market power. And so what we've done is we've really pulled out 4 facts. Facts that we think are critical for policymakers. And what we want to do is sort of talk about the implications of these facts. And I'm going to allow Marty to unpack more about the market power story in his section. Dan will talk a little bit about it, and hopefully we can loop back around in questions. But I think what we've come up with, and what I want to talk about in my last sort of 40 or 50 seconds here, is this amazing tension in healthcare policy that we've got to think about how to reconcile, which is that bigger hospitals often have higher quality. It's often where we want to go when we get sick, and that integration does have some virtues. But at the same time, bigger hospitals also have more market power. And I think what's pretty clearly happening is this is allowing them to get higher prices. And so we talk a little bit about our different policy options. I think one critical one, which Marty will go into, is antitrust enforcement. Being very, very careful about thinking about what happens when hospitals merge. I think second, it's thinking about regulating prices, if and whether or not that's a good option. I don't think it's phenomenal across the board, but in cases like out-of-network charges or trauma activation fees, that might be a place to think about. We can look at what's happened in Maryland, where their all-payer system, up until pretty recently, was not hugely effective at raising spending, and we can think about that. But I think some of the biggest gains are going to be made from making patients more price sensitive, putting prices out there, making them transparent, and basically creating a more dynamic market where a hospital in Boston isn't really viewed as, or is viewed fundamentally as competing with other hospitals across the country. So that I, as somebody in New Haven, Connecticut, can look to my local hospital here at Yale, look at my hospitals in New York, and also look at my hospitals up in Boston, and view them as competitors to one another. It's that sort of competition that we think, or I think, is so important to making these markets function. So with that, I'm going to turn it over to Marty, who's going to talk a little bit more about market power, and then we'll all loop back together at the end to talk about how we really begin to put things together going forward.
Thank you so much, Zach. Martin, we're going to turn to you and hear what's next.
Hi, folks. Glad to be with you today. Thanks for joining us, and thanks again to Zach for a great presentation and summary of our work with Stuart Craig and John Van Reenen. So what I want to focus on now are policy options towards healthcare markets. As I presume most people know, the U.S. relies on markets for provision and a lot of the financing of healthcare. And while we're aware of that, we do need to think a bit about what that means for the healthcare system. The key thing here is that the healthcare system is based on markets. Markets are like the chassis of a car. And that means the healthcare system is only going to work as well as the markets that support it. If the chassis of a car is broken or bent, the car won't run or it won't drive straight, and it won't matter if you put a new improved transmission in or a beautiful body or a new powerful fuel efficient engine. If the chassis that supports everything is broken, then none of those improvements to the car will work. And we've known for a while that healthcare markets don't work as well as they should or they could. We've had fragmentary evidence on what's happening with prices. I think our work gives more comprehensive national picture than anything we've seen before. We've known there are quality problems. We've known there's too little organizational innovation. Some folks feel that the system is far too fragmented. We need more coordination of care. And in my opinion, consolidation, concentration, and market power have a large part to do with these problems. They're not the only story, but they're an important part of it. We know that markets are highly concentrated, more consolidation is happening, and this matters. It matters a great deal. It matters for the functioning of the healthcare system. It matters for the Affordable Care Act and for health reform generally. So you've just heard from Zach about the new evidence we have on private healthcare spending, and I'm not going to review that. He gave you the summary of that very effectively. I will also mention, though, that there's a great deal of scientific evidence that already has been existed that shows that in many markets, hospital prices are lower where hospitals face more competition, and vice versa. For quite a few mergers, when hospitals are close competitors, those mergers lead to very large price increases. And we're not talking 1%, 2%, 3%. We're talking on the order of 20%, 30, 40, 50, even as high as 60% price increases. Really substantial stuff. Now, that other research is great research. It's not as comprehensive evidence as ours because none of that other stuff has national data, and they generally don't have the same kind of information about transaction prices that we do. But nonetheless, there is a very well done scientific literature on this that consistently shows that more competition, lower prices, less competition, higher prices. Now, again, like Zach mentioned, in principle, we could think that consolidation could lead to better quality, lower costs. All that sounds great, and there are some reasons to think that sounds sensible, but except the evidence is mostly it does not. The bottom line on this is I think that in our healthcare system, we're stuck in a rather bad state, and that state is one in which for healthcare providers, improving quality is hard and doesn't actually pay very well, and raising price if you don't have a lot of competition is easy, and there's a big dollar payoff to that. So what's going on with regard to consolidation? Here's a chart that comes from the American Hospital Association. There's been a lot of consolidation in hospitals. Starting in 1994, this chart doesn't go back that far, but I can tell you from 1994 there have been over 1,200 mergers in the hospital industry. There were a little over 5,000 hospitals back in 1994, so that's a huge proportion of the industry that's been involved in a merger, many hospitals and more than one. Starting in 2010 up till 2014, there were 457, a big tick up in the number of mergers in recent years. And we now have most urban areas in the country dominated by one, maybe two, maybe three large hospital systems. My home of Pittsburgh is dominated by University of Pittsburgh Medical Center. The Bay Area is dominated by Sutter. Boston by Partners. Cleveland has two, University Hospital and Cleveland Clinic. This is very, very typical. Whereas if you go back 20, 30 years, most of these places had 3 or 4 or maybe a half dozen or more independent systems. There are still a few places like Los Angeles and New York that have a number of effective competitors, but those numbers are shrinking, and they're shrinking very rapidly. Now, one thing that we can certainly talk about if people are interested is why this might be happening. It's commonly thought that the ACA is the primary driver here, and the ACA probably has something indirectly to do with this, but one thing for folks to be aware of is the same time we're seeing this big surge in mergers in healthcare, about the past 4 or 5 years or so, there's a big surge in mergers throughout the entire U.S. economy, and actually the global economy as well. So there's some things going on in the entire economy that are leading to mergers in plastics, in software, in the entertainment industry, et cetera, that probably have things in common with what's happening here as well. So let me move on. As I mentioned, it's not hard to imagine that there are some potential benefits of consolidation. We could get better coordinated care, higher quality, get rid of duplication. There could be scale that could be achieved. It could enable providers to better take on risk contracts associated with payment reform and so on. But one key thing is that merely consolidating doesn't mean that you're integrating. So if you're involved in merger or acquisition, that's only the very first step, and integration is really hard. And the research evidence, and there's quite a bit of it now, just doesn't support the claims. The evidence is that costs just are not lower. There's some evidence, but not a lot, of improved quality. No evidence that, say, nonprofits or publics increase their charity care, and no evidence in general that nonprofits are cheaper or better. Last, there's been some recent work looking at integrated delivery systems, and their vaunted reputation just does not hold up to inspection. Now, some of this perhaps is not terribly surprising. If you think about it, big isn't necessarily better. Some big organizations can have the scale to do certain things, can have the scale to do things better. On the other hand, often they can be very cumbersome and unresponsive. And in addition, there are a lot more people and infrastructure to support. If you want to change something, often it's easier to change within a small to medium-sized organization than a large one. So bottom line, being better is hard. And again, the current state of the U.S. healthcare system, being better doesn't necessarily pay off all that well. What are the concerns? The concerns are about mergers between close competitors. And as I said, the evidence is very strong for the hospital industry that mergers between close competitors lead to higher prices. There's also good evidence on this now for physician services, for health insurance, although not as extensive for hospitals. There is evidence that mergers can lead to lower quality. It's true for Medicare. It's less consistent for the privately insured, but I think the best evidence shows lower quality when there's less competition. And all these other things you can see on the slides: less investment in doing things better, resistance to better forms of payment or contracting. If you're big and dominant and a private payer comes to you and says, I'd like to do a tiered network, I'd like to do reference pricing, I want to do bundled payment, if you're the dominant provider in that market, you can just say no. Say, no, I'm not going to do that. I'm going to keep on with fee-for-service. If you want me in your network, that's the deal. Take it or leave it. You have a less dynamic, innovative marketplace. A couple other points to make here. There's already been so much consolidation in the hospital sector in particular that many mergers going forward will now be between close competitors because there are so few competitors left in many markets. So I mentioned to you the evidence on this. As I mentioned before, if you've eliminated competition, raising price, quote unquote, is easy, and it pays well, and unfortunately, it's much more profitable than trying to improve and do better in terms of quality or better organization and better management. So what's the problem? Well, in my view, we're facing a great challenge to our healthcare system. If left unchecked, consolidation could undermine the valiant attempts that are being made both in the public and the private sector to control costs, improve care, and give us a more responsive, innovative healthcare system, we're going to need new and vigorous policies to encourage beneficial organizational change and competition. If we fail at this, and we've got opportunity now within a few short years to do this and do better, then we could end up with an even more expensive, less responsive, reified healthcare system dominated by a few giants that will be very hard to change. And those giants, even worse, could become too big to fail. So what are some policy options? Well, Zach mentioned information transparency, and I think that our study vividly illustrates the intense need for information. We were able to do a lot with the data we have, but while we have a huge amount of data and what we have is unprecedented, we don't have complete information on everybody with private insurance in the United States. In my view, there's a need to create a comprehensive national data warehouse, if you will, as part of the nation's infrastructure so that we have good information about what's happening with utilization, about what's happening with costs, with prices, with various measures of quality, and can act on that. We need vigorous antitrust enforcement both by the federal antitrust enforcement agencies and by states. The feds have been quite vigorous, particularly recently, and some states have as well, but I think if anything we need to redouble our efforts in this area. There are a bunch of policies that I'll call rules of the road that enable and support competition or can do the opposite. They include things like transparency, scope of practice regulations, things that affect how easy or difficult it is for new innovative entities to get in, like certificate of need regulation and so on, market monitoring, and a lot of these are done by the states. Some states still have certificate of need regulation that mostly hampers the functioning of markets. Some states have been easing up on scope of practice restrictions, say for nurse practitioners and other kinds of medical personnel. Massachusetts has the Health Policy Commission, which has done laudatory work in terms of gathering information, analyzing it, making it available to the public and to policymakers and making a real difference. The federal government also operates in this area as well, particularly HHS. Payment reforms, of course, people talk about payment reforms a lot, and we know that that's important, but we need payment reforms that reverse the situation I've been describing, where raising price pays out well and improving quality does not. We need to reverse that, and it's important to realize that competition and payment policies are complements. If a payer wants to introduce new payment methods that would really be beneficial and improve care, drive down costs, and if there's a dominant provider and they don't want to comply, then those attempts to improve things will be thwarted. So competition is absolutely vital. Another thing that can happen is if there's a dominant payer, even if they agree to a payment method that would be superior in principle, if they negotiate because of their dominance a payment that's at a very, very high level, the incentives associated with the new payment method will be either very weak or non-existent because there won't be much pressure on the provider to do better. And so that's another way that lack of competition can thwart the payment reforms and payment policy. Last, as Zach mentioned, one thing that has increasingly come up for discussion is price regulation. Quite a few states used to have all-payer price regulation. Now Maryland had it. They've gone to global budget. There's mixed evidence on how well that stuff works, and politically it's a tough haul. But under some circumstances, if we really don't think that we can make markets work, price regulation is definitely an alternative to be considered. So thanks very much, and I look forward to engaging with everybody during the Q&A.
Folks, we're going to turn next to Dan Gorenstein. I just want to let you know that we'll be also providing a recording of this on Center for Health Journalism, and that you can tweet about this at the hashtag HealthCosts. Dan, how can we tell stories about all this?
Okay, great. Well, good morning, good afternoon to all of you. Thanks very much for joining this call. I just want to start out by saying I'm really psyched to be here with Zach and Marty. I think that these guys and their colleagues have put together really important work. Excuse me, I'm a little under the weather. They've put together really important work here, and I think when I learned about, I just want to kind of make a case. Like, I think, obviously, as Michelle asked, like, the idea is to figure out, well, this is interesting data, but how do you make an interesting story? But before we get there, I just want to sort of move along. And if we could go to, please, my first slide. Yeah, that slide. So, this is sort of a goofy little thing, but I think it underscores what Zach and Marty have been talking about. There is a real urgency, I think, and we heard this in what Marty was just saying. There's an urgency to what's going on, and I think it's a little bit hard to see. It's under the radar. But when you really think about what this paper is saying, we've known for a long time that prices are different depending on where things are. And I remember the conversation I had with my editor. Oh, well, what's new here, Dan? What's the story? And I said, the story is that we're learning, not only is this information not just about public, this is about private payers, but more than that, this is really understanding that monopolies and how much consolidation there is in a given market is one of the key, if not the most important factor in how much people pay. And so where we live, really, and the kind of environment, the kind of monopoly environment that there is on the ground has a huge impact on what we pay. And I think as you guys think about this and you think about taking this to your editors, I think that's a big idea. What is the monopoly landscape amongst healthcare providers in my community or my region or my state? And to begin to understand that and think about that, I think that's a very important piece. If we could move to the next slide, please. This is sort of, I'm stealing this from Zach. We won't be here long. I mean, this is just, the point is this is happening all over. This affects everybody who's on this call right now. There's something going on in your community or in your region or your state, and you need to know it. If we can move on, please. So I was talking to Bob London, the health policy professor at Harvard. Some of you, I'm sure, have talked to him. He's a great guy. He monitors public opinion, and one of the things, for the general public, it's just invisible. It refers to this consolidation, and Bob and I have talked about how, when you thought of we have these banks. We had the bank situation where all of a sudden the banks became too big to fail and no one knew. And this problem sort of came out of nowhere. And I think what's exciting about this report from Zach and Marty is that it's like one of these warning detector signs. It arms us reporters with some data and some information that we can run with, to say, hey, wait, what is going on? And to begin to ask some challenging questions. If we could go to the next slide, please. Thank you. So blended, if you look at this slide, which is a little hard, I am no expert at making slides here, I apologize. But this is not on anyone's radar screen. And when the election is coming up, people are concerned about healthcare. It's not as important as it was in 08 or in 12, but it's still an issue. But when you look at this slide, there are lots of issues that people are interested in: Medicare, Medicaid, et cetera, but consolidation is not on the list. And so what do we do as healthcare reporters? What do we do? So if we could just go to the actually, let's hold off. That's not good. Well, whatever. That's fine. Doesn't matter. Don't pay too much attention to this slide yet. So what I'm trying to do, and I'm actually trying to do a story on this for the next week or two, is I'm trying to, and I've talked to lots of sources about this, I'm trying to follow the bouncing ball. I'm trying to find, and I think this is something we can all pursue, I'm trying to find an example where there has been hospital consolidation, lots of mergers, and then find an insurer, a big one or a small one, who then, when they went to negotiate the next time around, found, you know what, its prices are more expensive. The hospital or the health system has more market power now, and so prices are going up. And what does the insurer do? The insurer passes that along to employers, and ultimately the employers pass that along to the employees. So how, you know, it's hard to do stories that really come alive if it's just data and numbers and big businesses making these deals behind closed doors. I understand that. But when you start, everybody is concerned about how much they're paying in their insurance premiums. And with the Affordable Care Act, that's a bigger deal than ever before. So that, you know, when premiums go up, that's a great time to kind of dig in and say, well, why are premiums going up? How much of this has to do with any consolidation? Are there any potential consolidation deals that are being batted around? And using insurers and employers and employees as a way of trying to, again, follow this bouncing ball of consolidation and the impact, I think we can all make these stories more come alive. At least that's certainly something that I'm trying to do. Now, this slide is the reason I got this slide, and this was actually thanks to Zach and one of his assistants. This slide helps talk about another fundamental tension, another piece of string that we as reporters can pull. And what this shows is, excuse me, again, I'm sorry, I'm a little ill here. What this shows is that the health systems are major employers. They're major employers. So they're consolidating and maybe they're charging high prices, but they're also so fundamental. They're bedrock to the economic landscape in so many communities. They employ us. And that is a fascinating tension, which I strongly urge you guys to explore. Okay, if we can go to this final slide, please. So this is just some like little tweet business. It's a little embarrassing, but I tweeted out a couple of weeks ago, it's on us healthcare journalists to connect the dots between consolidation and price. And I really believe that. I really believe that there's an opportunity here. This is an issue that is absolutely under the radar screen of almost everybody outside regulators, academics, health policy wonks, and healthcare journalists. And it's on us. It's really on us, as far as I'm concerned, to find ways to tell these stories so people can better understand what is happening around mergers and consolidation and prices, and how that is a part of the puzzle in this effort to control spending on healthcare. So I know I've probably run long. I apologize for that. Thank you guys for your time. I want to open it up for questions. And again, thanks everybody for joining this call.
Thank you so much to all three of our speakers. We have a number of questions already from people, and I just want to remind folks that you can go into the chat or question mode on your screen and type in a question, and we will be calling those out for our speakers. So I'm going to start out with a question from Karen Cameroon, who says, competition is only present when someone has a payment source. No one competes for the uninsured, and federal regulations require emergency departments and hospitals to provide care. I guess it's more of a statement. Healthcare is not a true market for a number of reasons, including imperfect knowledge of the consumer, another party directing the course of treatment, the urgency of the service to be provided, et cetera. Did either of you or any of you have a reply to that?
Yeah, this is Martin Gaynor. I'll respond to the second part of that statement. I think probably rather than saying it's not a true market, perhaps the thought is more that it's not a market that functions like a market for simple things like paper clips or retail gasoline or milk, and that's certainly true. But it is a market. We use markets to produce and deliver health care, and as I said, they don't function the way that we would like them to, but they do function. So I think that though healthcare markets work a little differently, and it may not be apparent exactly what's going on. So, of course, when we're buying something like a gallon of milk, we're paying for it directly out of our own pockets. We make all the decisions ourselves and bear all the consequences associated with that in terms of cost and quality. And here what happens is that a price is determined, as Zach said, via negotiations between private health insurance companies and providers. And if providers give health insurers the prices they find desirable as well as other characteristics, then they're included in their network. If not, no. So that's a key aspect of competition in healthcare markets. It's competition by providers to be included in a health insurance company's network. And let me be clear, I'm talking about for people with health insurance. I take the first point about folks without insurance. That's a different matter. Then once in a network, the providers in that network do compete with each other in order to attract the patients who have insurance through the insurer, but that's not generally on the basis of price because most of those people are heavily insured. That's more on the basis of quality or other aspects of service. So I think that this market can be understood. It just works differently than many of the simple markets that we're used to thinking about.
And just to add on a bit to what Marty said, and I agree 100%. It's worth flagging up some research that he's done and separately that I've done looking at England, right? The National Health Service, which is, we all sort of joke is the beacon of socialized medicine. And in 2006, Tony Blair, who's then Prime Minister, basically moved the NHS from not having patients have any choice, not having hospitals to compete, to having patients have free choice over where they went and having hospitals forced to compete to make money. And care was still universal, but they moved towards hospital competition. And both Marty and I separately found that change, forcing hospitals to compete, led to huge reductions in death rates. And so I think I agree entirely that markets in healthcare are different than markets in other sectors of the economy. But it's sort of easy to think, or I think the easiest way to think of them is sort of least worst, right? It's like the least worst way to provide healthcare. And we see evidence from countries that provide universal coverage that competition can also be helpful.
We have a question from Joe Magruder. Does the presence of HMOs such as Kaiser and Group Health Seattle have any impact on markets?
This is Martin Gaynor. You go ahead.
Yeah, go ahead. I was going to say, yeah, they do. And, I think they are. It's interesting to think how they behave as competitors. I think when you look at Kaiser, the incentives they face as an organization make a whole lot of sense. And so I think they do serve as competitors both to hospitals in their area and also to payers. Although I think one of the challenges, and it's easy to, I think Kaiser does a lot of things right and is a remarkable example. It has had trouble expanding. And, Kaiser really is sort of locked for the most part into one geographic area. So I think it's sort of part of the solution, but not the entire solution.
Yeah, this is Martin Gaynor. I Zach, but one of the areas of the country that actually is having a great deal of difficulty with the dominant health system is the Bay Area, where Sutter dominates, and of course Kaiser is very strong there. Things would probably be even more difficult there in the absence of Kaiser. So I'm not saying this to denigrate Kaiser in any way. In many ways it performs very well, but just to point out that the mere presence of an alternative like Kaiser, while it's valuable, in and of itself is not sufficient to drive an entire market.
We have a lot of questions from folks wanting to know, how do we get this data for our local area?
Yeah, so we've put up, basically every figure that I've presented today, we've posted online at healthcarepricingproject.org. I feel like I should put ads up there now since I'm saying the website so frequently. But what we've done is we've put the graphs of hospital prices for every HRR that we can report up there as well. So for 119 areas of the country, if you go to our website, you're going to be able to download those graphs. One of the challenges with this data is it is terrific, but it is commercially sensitive. And so there are limits to what we can report. So we can basically report in geographies where there are 5 or more hospitals, which is a little disappointing. We wish you could report everywhere, but we think is a nice first step and will help folks be able to see what their markets look like.
That's a perfect segue to our next question from Roger Smith, which is, would transparency, maybe call it public shaming, have any impact on hospital pricing?
Yeah, hi, this is Martin Gaynor. So that's a good question, and I think that the answer is definitely maybe. We do see that the activities of Massachusetts Health Policy Commission do seem to have been effective in a couple ways. One, really putting information out there about what's happening with healthcare spending in the Commonwealth, rate of growth of healthcare spending. That does seem to have had some effect. And more directly, they analyzed a recent proposed merger between Partners and South Shore Community Hospital, and that got the attention of the Massachusetts Attorney General, who acted on that. And the report that the Health Policy Commission put together and their analysis was very influential. So, there is the saying, sunshine could be the best disinfectant. So one might think even an area like Pittsburgh, which is nearly completely dominated by University of Pittsburgh Medical Center, if prices were made public, and if indeed they were very high, that might make it uncomfortable for the board of trustees, and that might lead to some action.
Yeah, and to add on it, I think Marty's 100% right. So one of the challenges we see is most people don't use information if it's available. So even if you put the price data out there, they don't use it. Now, I still think making prices transparent makes a lot of sense, and here's why. So right now, you've got some innovative companies like Castlight who are working to try to be transparency companies. And the competition in that sector is over access to data. So it's Castlight competing against other places, competing against the website like Guru, about who has the best data. And I would rather see the competition be over who can use their data most effectively to steer patients. And I think what's going to happen is if we start making these markets more transparent, if we start putting the data up there, if the federal government required it to be put out there, you're going to start getting these kids in Palo Alto and in San Francisco competing over apps that help us choose, or other innovative strategies to help steer people around. And so while I think that transparency, putting prices out there per se, is not going to immediately make things different, I think as we start getting that information out there, it's going to create, in a sense, the launching pad for more innovative strategies to use this in benefits designs and in apps and in all of the ways that we can't think of to make consumers better decision makers. The other is, I think there's something just outrageous about having an EMRI that costs 9 times more at one hospital. And I think, frankly, we've got an obligation to say to a patient, hey, look, if you travel 15 miles further or 10 minutes in the other direction, you can save several $1,000s. And so while that might not transform healthcare, it's going to make somebody's life a whole lot better. And I think even those small steps can be a really good thing.
Really interesting point, Dan. We have a question from Nathan Price. Would a single payer system offer better price control and improve quality?
This is Martin Gaynor. Well, that's interesting question, and the answer again is we don't know. I think it's likely, were there a single payer, prices probably would be lower because there'd obviously be only one source for providers to go to. Just how much lower, of course, one couldn't say. As far as quality, it's not evident. We do see places like the English National Health Service, where the level of total spending is lower, although actually the rate of growth of spending has been pretty similar to that in the U.S. Quality for a lot of basic services in the NHS is actually quite high, contrary to popular opinion. But I think the U.S. is still the world leader in terms of quality care for complicated and difficult kinds of conditions. What we can say about moving to a single payer system here, it's very hard. It's very hard to know how these things would play out. Although it's interesting that apparently it's at least a bit of a live issue now, which is not something that I would have guessed.
We're all feeling the burn. No, I think I love Bernie Sanders, and as a person from Vermont, he's done a good job in our state. But I actually think realistically, it's just not going to happen. Like I think the days of us, we're not about to move to single payer, no matter who gets elected president. So I think it could have virtues, but it's just not sort of a realistic thing that's going to happen.
We have a question from Jennifer McCormick. She asks, what about the trend of hospital systems buying up insurers? Will you discuss the implications of this on price in markets?
Sure. I'll take a first stab and then let Marty come in. I think, so we've got two problems. One is that in certain instances, there's too much care or unnecessary being provided, and then there's also really high prices for the privately insured. And I think when you see integrated providers, that is an organization that is both a purchaser and a provider at once, it creates incentives that reduce overuse. But at the same time, if you've got a very, very powerful integrated provider, it's still going to have the opportunity to charge high prices. So I think it gets you part of the way there, right? It's gonna sort of blunt to some extent some of the incentives to do a lot, but you're still going to have monopoly power. And so I think you really do want to see competition between integrated organizations, even if you allow this integration to occur.
Yeah, hi, this is Martin Gaynor. I think that actually there's some of this going on, but there's not all that much. There are some prominent examples. I honestly be surprised if we see this become a dominant model. But having said that, I think that these things often don't perform as promised. And one reason is actually, it's not hard to realize, is that hospitals insurers have different objectives, right? Insurers want to keep people out of the hospital. Hospitals make money when people show up. So you put them together, and how do you resolve that? They seem to be operating at cross purposes. That's one, and so it's not so easy to make that work successfully. The other is, at least in some markets, there's a danger when you do that it actually reduces competition in the market. The now integrated insurer hospital may have lots of incentives to try and exclude other providers for the benefit of the hospital, or try and exclude other insurers for the benefit of the insurance component. So that's one danger. Another thing, and I think we've seen this here in Pittsburgh, is when UPMC created UPMC Health Plan, what that did was give them more negotiating power against the large insurer in town, Highmark, a Blue Cross company, because they had their own health plan, and they had a better alternative than they'd had previously if Highmark tried to get tough with them. And I think what that accomplishes is higher prices for the now quote unquote integrated health insurance health provider system.
We have a comment from Diana Forrester. She says, over 75% of Texas is rural, and the cost of operating a rural hospital has been closing a significant number of these hospitals, affecting access to care. In these areas, consolidation is seen as a godsend, so it's interesting to see the negative side of it.
Sorry. Rural areas are different. Sorry, Sarah.
No, you go ahead.
Okay. All right. So yeah, rural areas are different, and the special consideration does have to be given to those areas, particularly if, and I don't know Texas in particular, but I do know Western Pennsylvania, and there are a lot of small towns or even small cities up and down the rivers here that have lost population, been losing population in the past 30, 40 years since steel went away. And I've seen a lot of hospital closures, and that's very, very painful for a community. But it's hard to keep an entire hospital open when your population has shrunk by 100% or more over the past few decades. So it's a real policy challenge for us in our states and for the entire country how we deal with that. I'll just want to make one comment. In terms of antitrust enforcement evaluating mergers, if a merger would save what would otherwise be a failing firm, it is possible under antitrust law to justify a merger on those grounds. And I think for precisely these kinds of reasons. So there may be some leeway for these kinds of situations, at least if it comes up as an antitrust issue. And Zach, I'm sorry that I jumped in.
No, you said it better than I would have. I mean, the only thing I'd add to that is, in those sorts of markets, and in markets where, in a sense, the merger has already happened and it's hard to unring the monopoly bell, I think those are places where we do have to think a little bit about price regulation and how to make pricing work in areas where competition isn't possible. I think the second sort of coda to that, though, is that I think going forward, if we sort of look 20, 30 years down the road, I actually really do think patients are going to be traveling considerably further for care. And I think this idea that you got to get all your care within 8 miles of your house both limits the number of really good providers that you can see and also blunts the incentives in those markets. And so I think that's something that I'd ultimately like to see start changing as we move ahead.
Well, I want to thank all three of our panelists for the many provocative questions you've raised. In fact, we could probably keep going for another hour based on the questions that are here in the queue, but unfortunately, our time is up. I just want to remind everybody that the slides of the three presentations will be up shortly on our website, centerforhealthjournalism.org, and that we should have the recording up soon as well, and that you're welcome to download all of those materials as well as a resource list that we have related to some of the topics that our speakers have touched upon. In addition, we'll be sending you a short survey asking you for your feedback, which is always helpful to us, and ideas for what you'd like to see in our next webinar. We'd ask you to take that survey, and we want to thank all of you for participating. Thank you so much.